Without further ado, our speaker today is Dr. Joe Kelly. Dr. Kelly is a native of Wilmington. He has established himself in private practice in North Wilmington. He graduated from the University of Maryland School of Dentistry in 1997 and has completed numerous continuing education courses, including those in dental implants, endodontics, aesthetic and cosmetic dentistry, emergency medicine, and laser treatments. Dr. Kelly is a member of the board of directors of the Academy Delaware Public Health Association and is a past president of the Delaware State Dental Society. So Dr. Kelly is here to talk to us today about dentistry. As always, Nicole and I will be monitoring the Q&A. Please put any questions you might have into the Q&A. And a reminder, if you are joining us by phone today, please just email nsabine@delamed.org and let Nicole know the phone number you're calling from and your name so that we can make sure that we have you down as attending tonight. Dr. Kelly, the floor is yours.
Oh, thank you. Can we do, okay, here we go. There we go. Okay.
That's it.
The profession of dentistry. I'm going to start off tonight, going over the profession of dentistry. I'm going to give you my story. We're going to dive into the world of dentistry, dental specialties, and also tooth decay 101. I started out at the University of Delaware. I want to go over my mentor, working for AstraZeneca for a year, the DAT, the University of Maryland School of Dentistry, and then the Christiana Care general practice residency, and then private practice. Believe it or not, I started out at the University of Delaware and I graduated with a degree in political science. I thought I was going to go to law school, but I had a grant studying the Delaware Constitution my junior year. And I said, this isn't for me. And that same year, I started taking science classes because it was a Bachelor of Arts degree. And they required certain science credits. And then I started leaning towards the sciences. I had an ecology class with Dr. Lotrick. And I still remember his first line of that class. And he said, "Is a desert a desert a desert? I don't think so." And believe it or not, just with that simple line, he kind of had me hooked. Started piling on the science classes because I just really enjoyed them. I'll get into my mentor, but my mentor kind of intervened and said, you should really go to dental school. They did have a board at the time, which you had to sit through at the end of my college career. And we had to interview with different professors in order to get the recommendation. My father's friend was a dentist and he became my mentor. He's the one that, saw that my interest in sciences were peaking. And he's like, look, we really need good dentists. We need strong students. You should really go to dental school. And I think that's key for anybody that wants to go to dental school is to find a mentor, find somebody that they trust, find someone that has gone down this similar path, reach out to your family dentist or shadow at an office, just kind of develop some type of professional connection. I think you'll find that these dentists in the community will be more than happy to help you out and answer your questions. And it's just a very important aspect. When I graduated, I didn't go right to dental school. My senior year summer, I had an internship at AstraZeneca. It was excellent. I got to perform dissections of animals for urinary incontinence and pulmonary hypertension, and it was great hand-eye training for dental school. So you don't necessarily have to go right into school after you graduate. And it was an excellent experience. And then I got to stay on the year there. I kind of had a gap year, and just excellent training, excellent community, excellent to be around such wonderful scientists and professionals. So after my senior year, I took the DAT. It's broken down into, it's got a natural sciences It's got biology, general chemistry, organic chemistry. It's got a perceptual ability section, which is very unique. It's 2 and 3 dimensional problem solving. There's a reading comprehension, which makes sense. It's just dental basic sciences. Then there's quantitative reasoning, mathematical problems, conversions, and it's accepted by 66 dental schools. It's about a 4.5-hour exam. Very important to prepare for it, whether it be through a preparatory course. I studied at home through material that I acquired through a friend. And also the timing of the exam should be considered. After you've taken organic chemistry, may be a good time to take it if you've taken most of your basic general sciences. They say the biology section is the toughest to prepare for due to the sheer volume of the material. So from University of Delaware to AstraZeneca, and then I went to University of Maryland School of Dentistry. It was a 4-year program. First 2 years were coursework in sciences and dentistry, along with the labs to prepare you for your clinical years. Then the last 2 years are clinical. You're in the clinic working on patients, and coursework focused on dentistry. You're getting more out of the basic sciences. We had 2 board exams, part 1 and part 2. Part 1 is after your 2nd year of school, and part 2 is during your 4th year of schooling. You had to perform a defined number of procedures for graduation. So you have to do so many crowns, so many fillings, so many extractions, dentures, partial dentures, root canals. You have to gain that experience because you're going to be entering into a profession in which you're going to be seeing patients. And so you have to get the procedures for graduation. And then there's a clinical board required to gain licensure. And that's just kind of a rite of passage. You take the board, and obviously, hopefully you pass, and then you get your license to practice. After dental school, I did a 1-year general practice residency. Now in Delaware and in New York, that's required for license. But most people graduate, do some form of residency, whether it's a GPR, which is general practice, or advanced general dentistry, if they don't go into a specialty. Now, GPR is a 1-year hospital-based residency in general dentistry. There's an anesthesia rotation. There's an emergency medicine rotation, which was excellent. You just get exposed to a great deal of pathology in an emergent situation. There's an oral medicine rotation in which you are basically clearing patients for heart surgery or valve replacement. Combine that with diagnosing oral pathologies. And then there's an oral surgery rotation, which is self-explanatory. You're doing a lot of extractions during that time. There's an on-call schedule for dental emergencies. There's a general dentistry performed in the clinic. And then you have a wide range of lectures covering a wide array of dental topics and provide practical experience in emergency and multidisciplinary comprehensive oral health care. You expose you to a wide variety of cases when you're working in this setting, special needs and medically complex patients, which is important for when you're out in private practice. And then you understand the oral health needs of the communities and take part in community service. And then you function effectively within the hospital and other healthcare environments. So it gets you experience, which is a tremendous asset. Now, when I got out of the GPR, I went and worked as an associate, which you're basically an employee for a dental practice. I worked numerous years there, kind of gaining experience. And then I became an owner of my own practice, which I'm practicing currently in North Wilmington. We provide a wide range of comprehensive oral health care services such as restorations, crowns, bridges, sealants, teeth whitening, cosmetic, dental implants, emergency dental care. You diagnose and treatment plan for common dental issues, typically the first point of contact for individuals seeking dental care. And GPs make up about 78.2% of the population of practicing dentists. We refer patients to specialists, and we also direct the multidisciplinary team when treating complex cases. You kind of act as the quarterback for these patients. Now, you could also elect not to go into general dentistry. You could elect to go into endodontics, and areas focused on dental pulp and periradicular tissues. They're, for the most part, doing root canals. Sometimes they handle trauma and manage those cases of dental trauma, but for the most part, you're doing root canals. Orthodontics and dental facial orthopedics. Obviously, if you want to straighten your teeth, you can go to an orthodontist, but also they get into correcting facial deformities, and these cases can be quite complex. There's pediatric, there's periodontics. Periodontics is the profession where they treat and diagnose gum disease, which can be critical for maintaining your teeth. Prosthodontics provide restorative dental procedures, including dental implants, crown, bridges, dentures. They also perform cosmetics. Then there's oral and maxillofacial pathology, concerns with the diseases affecting the oral and maxillofacial regions. And then oral maxillofacial radiology, which is a fairly new specialty. We have a cone beam within our office. We will send out cone beam to get scans to get read by the oral maxillofacial radiology. In fact, we just sent out 2 today. We have oral maxillofacial surgeons. They do a lot. They can get a dual degree with medicine. They do very complex surgeries. They do third molar extractions. They do orthodontic cases in which they're correcting the jaws. If there's a severe discrepancy, reconstructions, cleft lip, cleft palate, bone grafting, dental implants. They do a lot as far as anything in the surgical arena. Then there's dental public health. This discipline focuses on the prevention and treatment of dental diseases and promoting dental health throughout the community. So those are all the specialties. I don't know why oral surgeons, this is when they were accepted by the ADA. I don't know why oral surgeons were 1990, but it's quite a bit. But now a general practitioner may do root canals. They may do extractions. They may do implants, but they always have the specialists to refer to and have their patient treated if warranted. So let's dive into the world of dentistry. I'm just going to briefly go. I mean, obviously, we know dentistry is a branch of medicine that focuses on your teeth and gums and specializes in an oral cavity. It's kind of like a subspecialty within medicine. Oral health is important because it affects your overall health. Your mouth is the entry point for many things that enter your body, including food, water, air. Poor oral health can lead to problems like tooth decay, gum disease, bad breath. In severe cases, it can contribute to heart disease, stroke, and other health problems. So what exactly is tooth decay? We call it dental caries. It's otherwise known as tooth decay or cavities. It's a common problem that affects all ages. It's a disease that occurs when the bacteria in the mouth produces acids that dissolve the hard outer layer of the teeth called enamel. Over time, these acids can create a hole or cavity in the tooth, And if left untreated, the cavity can become larger, deeper, leading to pain, infection, and even tooth loss. There are several factors that contribute to the development of dental caries. The most important fact is poor oral hygiene. And you know this. It allows the bacteria to accumulate and produce acids that cause tooth decay. But other contributing factors can be xerostomia, which is dry mouth. But if people ingest high sugar or carbohydrates, or lack of fluoride in the water and toothpaste, and then, like I just said, certain medical conditions that reduce flow of saliva, which we call xerostomia, which helps, the saliva helps protect the teeth and buffer the acids. This is a gross example of tooth decay. There's generalized decay throughout this patient's mouth. All these teeth were able to be restored, but this is what it looks like in its gross form, but doesn't necessarily have to prevent as such a severe case as this. The stages of tooth decay are initial demineralization. This is the earliest stage. White spots, sometimes you see this with your classmates or friends where they have white spots after, say, orthodontics. Maybe they weren't brushing as well as they could have. This may appear on the tooth surface. It's a sign of early decay. It's important to address by improving oral care and diet. Then you have enamel decay. Decay progresses. The enamel is further eroded. The underlying, so you have a structure of the tooth. You have enamel, and then underlying you have the dentin, and then within that is the dental pulp or the nerve. The decay reaches the dentin, which is the layer beneath the dentin or beneath the enamel. That's dentin decay. And then the decay can progress even further and reaches the pulp, which contains nerves and blood vessels. And this stage may or may not be painful. And then you can get the abscess formation, which is it develops at the root of the tooth. This is due to the fact that the bacteria in the decay or in the oral cavity have opened a cavity that involves the pulp, and then the pulp dies, becomes necrotic, and the bacteria are then populate the root canal and causes the abscess, or the body reacts and forms an abscess around the root of the tooth. So what's the main cause of decay? It's the Streptococcus mutans. It's a type of bacteria commonly found in the oral cavity. It's considered one of the primary etiologic agents in the development of dental caries, which is the most prevalent disease worldwide. Strep mutans is able to colonize the surfaces of the teeth, particularly in areas where there's a buildup of plaque. Once it has colonized the tooth surface, the strep mutans produces acid as a byproduct of its metabolism of carbohydrates, particularly sugars. The acid production causes a drop in the pH of the surrounding environment, leading to the demineralization of the tooth enamel. Over time, this demineralization can progress to the point where a cavity is formed. Strep mutans is able to produce glucans, which are sticky polysaccharides that allow the bacteria to adhere more firmly to the tooth surface, further contributing to the formation of dental plaque and caries. In addition to its ability to produce acid and adhere to the tooth surface, strep mutans is able to form biofilms, which are complex communities of bacteria that are embedded in a matrix of extracellular polymeric substances. These biofilms are resistant to the mechanical removal, as well as to the action of many antimicrobial agents, making them difficult to treat once they get to that stage. Now, there's strategies to promote remineralization of tooth structure and also to prevent decay. Effective management of dental caries requires a multifactorial approach that includes measures to control the growth and activity of the strep mutans, as well as strategies to promote remineralization of the tooth structure. Remineralization is a process by which minerals such as calcium and phosphate are deposited back into the tooth structure, thus repairing and strengthening the enamel. And so there's several strategies that can be used to promote the remineralization. One is, and this has been a godsend, the fluoride treatments can be applied topically to teeth in the form of toothpaste, mouthwash, or professional fluoride varnishes. Fluorides also inhibit demineralization and enhance remineralization at the crystal surface. The resulting remineralized layer is resistant to acid attack. So once you get this infusion of the fluoride into the enamel, which is typically up to 4 microns, it also makes that enamel more resistant to demineralization. And then the fluoride also inhibits bacterial enzymes, which is significant. Then there's dental sealants. Now, dental sealants are a thin plastic coating that are applied to the chewing surfaces of teeth, particularly molars, to protect them from decay. They help prevent food and bacteria from getting trapped in the grooves of the teeth, reducing the risk of decay and promoting remineralization. And that's just a plastic coat that's placed on the surface that just fills in the grooves and makes it easier for that area to be cleaned with a toothbrush and not as likely to form plaques within the grooves. And then there's calcium and phosphate supplements. Calcium and phosphates are essential minerals for tooth remineralization. Supplements in the form of mouth rinses, toothpaste, or professionally applied treatments can help to deliver these minerals to the teeth. And then there's xylitol, which is a sugar substitute, and that's been shown to reduce the growth of strep mutans and thus the risk of decay. It's often found in sugar-free gum or mints that can be used as a dietary supplement. The xylitol is converted to xylitol 5-phosphate, X5P, and then after its uptake into the bacterial cells, the X5P may inhibit bacterial metabolism, including acid production, and thus the xylitol retards the growth of strep mutans. And then there's, the obvious, which is oral hygiene practices, regular brushing, flossing. There's other modalities that can be used to remove food and plaque from the teeth, reducing the risk of decay and promoting a healthy environment for remineralization to occur. It's important to note that these strategies are most effective when used in conjunction with a healthy diet and regular dental checkups to monitor and treat any early signs of decay. So how do we treat decay once it's formed? It can be restored in various ways. Our most common is dental fillings. What you see in the top picture is 2 failing restorations. You see in the middle picture, the restorations have been removed. And then the bottom picture, you see they have been restored and with a good result. So let's just start with step 1. So here's a tooth. There's a little bit of floss stuck between there, but here's a tooth with a failing restoration and a crack. So this restoration has to be removed, the decay has to be removed, and the crack has to be addressed as well. So what we'll do is we'll take our handpiece, go in, start the preparation, take out the filling. You can see that crack line going off the backside of the tooth. So we want to break the contact. This is where, hand-eye coordination is critical. And since you're working on inside of a mouth on a small tooth, and so that this is prepared a little bit more. If you look towards see if my mouse, I don't know if you guys can see my mouse arrow, but if you look towards the margin there of the enamel and the dentin, there's decay there further. So we want to open that up a little bit more. So this is clean. This is acceptable. The dark area that you see towards the middle of the tooth, that's considered sclerotic dentin. As long as that's hard and not soft, then we're good to go. And what we'll use sometimes is disclosing solutions for caries to help with us identify soft areas of the tooth. But this is pretty clean here. Then we place a matrix on the tooth. There's a wedge that goes between the tooth. There's a ring that helps stabilize our metal matrix that helps with the contours of the tooth or the contours of the restoration. So once this is put on, we were able to place an etch on the tooth, which opens up the dental enamel, and then also the tubules within the dentin, and allows for the adhesive to flow into those areas and form a bond to the tooth, which we can then bond our filling material. And what we do, the filling material and the bond will go in soft, but then we will hit it with a light. It's a specific white light that will set up the material and then make it as hard as it's going to be. So this is the final restoration, and that's kind of a 101 as far as tooth filling. Now, this is a little more significant. This is two teeth that have been broken down. They had previous crowns. There's some recurrent decay underneath. And, this is extensive decay and damage. And the damaged portion of the tooth is removed and covered with a crown, which is a custom-made cap that covers the entire surface of the tooth. So we start out with this by, again, taking out the decay. It's been built up. The tooth structure has been built up with a composite or a build-up material was what we call it. And then the tooth is prepared. And it's prepared with a taper so that it can receive a crown, so that the crown can go on and off and not have any difficulty or interference with seating. And it's prepared. This is showing that it's prepared with different grits of a diamond on a handpiece to make it smoother and smoother. And then what will be placed is we usually typically place a cord around that tooth that will help with our scan. We will take a scan of this tooth, send it to a dental laboratory. Then the dental laboratory will send back the crown, and then that crown will be cemented onto this tooth and act as a replacement for the lost tooth structure. So here we are with the cord. This is what we look at for the impression or scan. We use a digital scanner at our office, but other offices will use a impression material to take a impression of this or a scan of this, send it to the laboratory, and then the laboratory will make the crowns for this patient. And then here we are restored. And these are the crowns cemented in place and with a very good result. Now, I talked to you about the decay getting into the nerve, or actually it starts off in the enamel, then it can get into the dentin, and then from the dentin it can get into the nerve. If you look at the step one photograph, you can see that shadowing on the tooth, on the last tooth, and that shadowing in the middle of the tooth is where the nerve is. So what has to be done is that decay has to be cleaned out. The nerve has to be accessed. Then the nerve has to be removed with instruments and series of files, and we use ultrasonics, and then also we use medicaments that help sterilize and reduce the bacterial population within that canal. And then what we use is a rubberized gutta percha. It's a filling material called gutta percha, and it's placed into the canal with a sealer, and then that root canal system is sealed off. And what you see in step 3 is the completed root canal with the buildup in place. And then you can see some sealer at the end of that root that's escaped, but that's fine. That actually represents a good seal. Here's another one, step 4. Again, you can see the decay in that second to last tooth. Again, you've taken away the decay, you get into the root canal system, and then you place the gutta percha in. And then you can see on the last one, the sealer has gotten out into the middle of the tooth. And what that represents is just a lateral canal in which the sealer has sealed off and flowed out of the root structure into the bone. As long as it's minimal, it's not a problem. So a more complex form of restoration is dental implants. They're used to replace teeth that have been lost due to decay or other factors, but a small titanium post is placed in the jawbone and a custom-made artificial tooth is attached to that post. In this case, there are multiple teeth that are being replaced. It's the whole entire arch. And if you look at the top photo to the left, you can see the dental implants peeking out of the gum tissue. And then the next photo is those black are used for scanning. So this arch was scanned, and then crowns were placed. This is a temporary that is next. And then the bottom photo shows you the before and after of the final restorations versus what the patient started out with. This can be very complex. It can involve bone grafting procedures. It can involve sinus lifts. It can involve multiple surgeries. It can take months upon months. Usually you have to allow for 4 months of healing at least. Can be very complex. Here's another patient, same deal. The one photo on the left is just showing us matching the gingival shade prior to sending off to the laboratory to get a prosthesis made. This is a fixed hybrid prosthesis in which the teeth are screwed into those implants, and the patient has a fixed or a prosthesis that does not come in and out. These do not come in and out once they're screwed in. Now we can retrieve them within the dental office, but the patient themselves would not take these in or out. And then this just shows you an X-ray or a radiograph of the dental implants in place. They are placed into the bone, and there's a process that we call osseointegration. The bone grows into the implant over a period of time. It's just not a mechanical lock. It's a biological lock in that the bone will grow into the implant over a period of time and provide a significant anchor for a dental prosthesis or for a single tooth. And again, here's just another example of the before and after of a dental implant case, which can provide a tremendous service for the patient, especially when they're faced with significant decay or periodontal disease. Another way of restoring teeth is through a bridge, and it's much like what I showed you with the crown, except you have a missing tooth, and the teeth on either side are prepared for the crowns, and then a bridge is cemented on. Again, this is a fixed, what we call a fixed solution. It does not come in or out. Once it's cemented in, it stays in. And but not by dental implants. You're using natural teeth. The downside of it is sometimes you have to prepare a tooth that really doesn't need a restoration, but needs to be prepared because it's going to be the abutment to the bridge or one of the anchors for the bridge. And then there's partial and full dentures. They do come out. They do provide a service for the patient, but they do come out. Sometimes people become tired of having to take something in and out and want to move on to a fixed solution such as a bridge or implant retained teeth. But here's a denture. Now this would be for an upper and lower arch. So it'd be a complete. The upper dentures work very well because you have a palate and they form a suction. The lower dentures don't work so well because it's hard to get a seal or a suction because of the tongue and not having a palate-like surface to form a suction or a seal. So what sometimes people will do is they'll get an upper denture and then on the lower, they'll do something with implants. You can make it so that the implants or the denture snaps into implants, or you could go for a fixed solution, something that would not come in and out. You can get into cost considerations with these cases. And then this is just a partial denture. This is when you use teeth to help secure a denture. The one on the left is a Valplast. It's a flexible acrylic material that does not have any metal in it and can be very aesthetic. The third one is, or the middle one is one with a metal retention. It can be very stable, but again, sometimes patients don't like it because of the aesthetics. And then the third one is just, again, a flexible acrylic that patients like because of the aesthetics. So that's kind of dentistry 101. The main cause of decay is the strep mutans. And I just wanted to review how I got to become a dentist, and then also how to restore various teeth with either restorations or crowns or implants. So are there any questions?
There are questions in the chat, and that was very fascinating. I will admit that dentistry is the one medical profession that like makes me cringe when I see like the implants where the teeth should be. I just ugh.
I know, it's crazy.
All right, there are quite a few questions, so let's just start at the top. The first one, Which field is the best for beginners to start in when they graduate from from dental school? Sorry.
I mean, you'd start off as a general practitioner. And then, I mean, I think the best way to do it is start off as a general practitioner. And then if you want to go back to school for a specialty, you'd go back and then you'd have some experience underneath your belt. So, and I think a lot of guys are doing that.
Okay, so questions about braces first. How do they work?
So the braces will put pressure on a tooth, and the tooth is connected to a root, and it causes the bone to remodel. Within bone, there's osteoclasts and osteoblasts and osteocytes. They allow for the bone to remodel. You want to think of, I mean, kind of anecdotally, you think of bone as kind of something that's very hard and concrete, but in fact, it's very dynamic. And so it allows you put consistent small amounts of force on a tooth, and it will cause that bone to remodel and allow that tooth to move through the bone.
Follow-up question. After you have braces and there are brown spots on your teeth, what is that called? Or what is it?
So that's usually a hypocalcified area with some staining. There's usually I treat that with a restoration if the patient wants to correct that area.
Why use silver?
So the silver fillings, or what we call amalgam fillings, they're very easy, I shouldn't say easy, but they're very straightforward restorations. And they are good restorations in that they can last a very long time. Their drawback is that aesthetics, a lot of people don't like to have silver fillings in their teeth. And then also over time, since the silver filling is very hard, we tend to see cracks that tend to emanate from the filling into the tooth. So that can be a problem as well. But they are very good serviceable restoration, but they're just are slightly out of vogue.
What other materials can be used for fillings, and how are they synthesized?
So they're methacrylate-based restorations. There's a filled resin, and then there's a filled resin. You can also use different ceramic materials to make a restoration. But for the most part, we use what we call composite, and because that can be directly made. If the ceramics, you have to fabricate either through a milling machine that some practitioners are putting in their office, or you have to send it out to a lab. But if you're milling it in your office, then that takes time. So there's got to be a workflow figured out as well.
Actually, there's a question here. How are white spots on the teeth treated, and should it be concerning?
Not necessarily concerning. I mean, you want to improve hygiene, to kind of hopefully have those white spots remineralized. It can be treated with an infusion process with somewhat mixed results, or it could be removed, and then a white composite filling that matches the tooth color can be placed.
Is pulpitis a result of tooth decay, or are there other causes?
It can be the result of tooth decay. There's two forms of pulpitis. There's reversible, and then can be irreversible. And then what we term necrotic, that's when the nerve is dead. That's not really a pulpitis, but those are kind of the three states. of pathology, but other things can cause it. If you fall down and hit your tooth, that can cause a pulpitis. And that can be reversible in that, in other words, the health of the pulp will revert back to a healthy state, or it can be irreversible, in which case it's not going to revert back to a healthy state and would have to be treated. So decay is not the only thing. Even the mechanical trauma of us doing a filling can sometimes be enough to cause a reversible or irreversible pulpitis. So it's just not decay.
Couple of benefits questions. Are electric implements like electric toothbrushes and water flossers better than conventional manual tools?
I don't know about water flossers, but the electric toothbrush is excellent. I think they're a tremendous investment for your oral health. Without getting into name brands, but just make sure it's a good one. But they're excellent devices.
Cool. Nicole, you want to take some questions? I don't need to be the only one talking.
Sure, yeah. I've seen a handful of people asking, I guess, which are better, the traditional braces or Invisalign, the invisible straighteners?
It depends. I'm not trying to avoid the question here, but it depends on the case, to be honest with you. And it also depends on the patient. In order for the invisible trays to work, you have to wear them very consistently. And if you don't wear them, then you're not going to get the movement or the force that's needed on those teeth. The beauty about braces is that once they're put on, they're there. They're gonna be doing the movement that you need. But it depends on the case. Some cases are set up for invisible trays, and then some are better with traditional braces, but it depends on the bite.
We also have some questions about sensitive teeth and why does it occur and how concerning is this?
So sensitive teeth can be caused by numerous things. If you have gastric reflux, that could cause sensitivity. If you grind or clench, that can cause sensitivity. If you have decay, that could cause sensitivity. So that's why the 6-month cleaning or routine checkup is excellent to help identify what could be causing the sensitivity.
We also have a question, can a person get a tooth sealant even if they don't have any cavities?
Yes, that's where you would do a sealant to prevent cavities. You would not want to put a sealant over a tooth that has decay on it.
Happened to me. I had that.
We also, along kind of the same lines of cavities, and why does the drill have such a high-pitched, annoying noise?
Yeah. Well, first of all, it's inside your mouth, which the sound is transmitting through your skull. So there's that factor, but it needs to be moving at a high RPM in order for it to efficiently cut through the tooth surfaces.
Oh, we have a lot of filling questions. So this person asks, do you recommend the gray color filling from the 80s and 90s to be removed and replaced with white filling? And how long do you recommend individuals to keep the gray old filling?
Well, I mean, again, that's case dependent, but I mean, if there's not a problem with that filling, then I would not replace it. In our practice, we look for a specific problem in order to replace those silver or gray fillings.
Here's a question. What's the difference between DDS and DMD, and why are there both designations?
Yeah, that's a very good question. So University of Maryland was the first dental school in the country. DDS stands for Doctor of Dental Surgery, and that was their designation. I think at one point Harvard decided to break off from the DDS and use DMD, which is Doctorate of Medicine in Dentistry. They're both the same. There's not a difference in philosophy. I think some schools followed Harvard's designation and went to DMD, but the training is the same.
I guess
And
along those
there's a
lines.
philosophy difference either.
Okay. Sorry. Along those lines, we also have a couple things about which is the best dentistry school, if you can measure that.
University of Maryland.
Yeah, there, Temple's excellent. U of Penn is excellent. I mean, I'm just thinking of schools within the area. University of Maryland. I can't say that I can't come up with one that you would consider a bad dental school. So I think they're all very good.
What would you say is the most common barrier to dental care in patients that you've noticed?
Cost.
Hmm.
I would say cost. It's there's a cost to doing the prosthesis. Like you saw those implant cases, they're not inexpensive. And there's a lot of work and time placed into those cases. So I would say cost is the biggest barrier.
Can you talk a little bit about why, if somebody's had like a hip or a knee replacement, you give one antibiotic capsule before any kind of dental procedure?
So it shouldn't be. So the thought is that when you have a dental procedure, that the bacteria can enter the bloodstream via the mouth, and then the bacteria within the blood, which we call bacteremia, can congregate on that joint because of the surface, the titanium surface, or whichever surface is present there. So it would make you prone to that. Now saying that, this isn't without controversy. Some infectious disease docs don't believe that's the case. The ADA has a statement saying that there's no high quality peer reviewed evidence that verifies this, but I'm very good at teeth. I'm not very good at joints. We consult with the orthopedic surgeon that's done the joint, and we follow their parameters. But it wouldn't be just one pill. It would be with amoxicillin, it would be 4 tablets, which of 500 milligrams, so that's 2 grams, or clindamycin would be 2 tablets. I guess the azithromycin could be 1 tab of 500 mgs. But that's the reason.
Nicole?
Yeah, kind of like a two-parter. So we had a couple questions about tooth whitening procedures. Is regular tooth whitening procedures in an office or white strips at home affect long-term use? And also secondary, can you use whitening strips with braces?
Probably the whitening strips with braces probably wouldn't be advisable because the braces would interfere with the placement of the strips on the teeth. So that would not be advisable. What was the other part?
Does the regular in office or whitening strips affect long-term use?
Long-term use. No, it wouldn't it doesn't have any long-term ramifications as far as the teeth. It's just that when you do bleaching, that can be a cause of hypersensitivity within teeth.
What is the white thing they coat your teeth with before they put the braces on?
Probably a prophy paste so that they are taking away the pellicle layer on the tooth. It's a thin microfilm that just forms naturally on your tooth. You take that away, and then it helps with the bonding of the brackets.
How about, are dental decay issues hereditary?
They can be. They can be. But there's usually a multifactorial. But like I said earlier, I mean, it could be hereditary in that gastric reflux could be hereditary. And then that reflux or acid is causing problems with the teeth. But yes, there's a hereditary component, especially with periodontal disease.
All right, this one hits home because this happened to my sister. In the case of people who don't have a grown-up tooth after their baby tooth, why does that happen, and is it hereditary?
That it can definitely be hereditary. It's just that the tooth bud did not form, the underlying adult tooth did not form, and we tend to see it, and it's usually there's a hereditary component to it. Now, you can treat that differently too. Like, for the most part, we usually just hold on to that baby tooth and try and get as much mileage out of it as possible. But after a while, I mean, maybe into the 5th decade, that tooth can start to break down, and then you could do a bridge or an implant in that area after you extract the tooth.
We also have some questions about fluoride. Why
Yes.
is fluoride good for teeth, but not in the body?
That's a good question. So the fluorides that we are using are very low levels. There's some controversy with fluoride in that it's a free radical, so that can have certain groups feel that that's not a good thing, which is understandable. But the health benefit of the fluoride itself on the teeth is tremendous, and helping prevent decay.
So along those lines of the potential free radical harmfulness, is there amount that one should limit to how much fluoride they use, or should they stop at a certain age?
Well, it depends on the situation. I mean, if you're having decay issues and you're in your 80s, the topical fluoride can be very helpful. It just depends on the situation. The fluoride levels that are in water are deemed very safe, and then topical applications at the dental office are deemed safe as well. So, I mean, like anything, you don't want to go overboard with something, but at prescribed levels, very safe.
Speaking, I guess, of going overboard, someone asked, is it possible for the dentist to drill your teeth a bit too much that the tooth turns sensitive during removing cavities?
So that can be dependent on a variety of factors. It can be if that pulp is already inflamed. It can be based on the depth of the decay. Sometimes the decay keeps on running and can get very close to that pulp. It can be based on the level of anesthesia. Like, sometimes somebody will need more anesthetic during a procedure. It can depend on the anatomy of the particular person. Sometimes you can have some aberrant fibers, nerve fibers that can cause sensitivity, that in most of the population would not. And so it can be based on a variety of factors.
Still kind of on the same wavelength. We have a question. Why do dentists use a numbing shot when pulling teeth if they also use numbing gel on your gums?
So the numbing gel is just a topical. That would definitely for tooth extraction, you want more than a topical anesthetic. That the topical or the gel is just placed so that the patient feels the needle is felt less during the application of the local anesthetic. And that's done by either infiltration or a nerve block.
What is the best way to fix a recurring chip on a tooth?
That can be,
Stop eating metal.
that
No.
can- yeah, that can be a problem. It can be a problem. It can depend on your bite and your relationship to your teeth. It can also depend on the size of the filling. Sometimes when we place just a thin layer, that's more prone to fracture. And also it can depend on habits like fingernail biting or opening packages with teeth, are not recommended.
Here's
If-
oh, you
Go
wanna
ahead,
go?
go ahead, Nicole. Yep,
Okay.
we'll go back and forth. Go ahead, you turn.
The interesting question, what happens if a person starts growing teeth on the roof of their mouth?
That's a problem. Yeah, that can happen. You can have teeth in malposition. Usually they can be, that case can be corrected orthodontically. If they're extra teeth, sometimes people can have supernumerary teeth. Then those teeth would be extracted. And then also today I saw a individual with wisdom teeth that were coming in on the palatal side of his dentition, and they would just be extracted as well.
That's unfortunate.
Mm.
Sounds awful. If a patient has received radiotherapy on the head and neck for cancer treatment, should he or she avoid a dental routine exam X-ray?
No. So you want to keep up on your dental visits and your x-rays so that you can detect decay early. Well, if somebody's had radiation to the jaw, it depends where the field of radiation is, but usually teeth in that area, you do not want to extract. So you want to catch decay early and address it with a filling rather than get to a point where the tooth could not be restored and then run into issues from that standpoint. With radiation, you can run into problems of what we call radiosteonecrosis of the jaw if a tooth is extracted in that area.
So we have two questions that kind of talk about genetics. Someone asked if infected teeth, well, how often do you see infected teeth and are they genetic?
I mean, so the genetics can play a role in getting decay or kind of, based on your saliva flow or your, again, I keep on going back to reflux, but they wouldn't cause the infection. Your genetics wouldn't cause the infection.
And then the follow-up is anodontia hereditary? Anodontia? I think I'm saying that right.
Dontia?
Lack of teeth.
Lack of teeth. Yeah, that could be hereditary. Yes.
Is that also why some people grow extra teeth? Hereditary?
Yeah, that could be. Yeah.
All right. What resources do you think people should look at to learn more about dentistry?
It's a good question. I mean, depending where you are in school, I mean, if you're in high school, I think just trying to reach out to your family dentist is an excellent resource, or your individual dentist. If you're in college, usually they have some type of club or group that is comprised of prospective dental students. So that's an excellent source. Just surfing the internet as far as looking at the ADA and also, looking on YouTube or Instagram can be good sources to look at procedures being done or different forms of dentistry.
What are the pros and cons of being a dentist?
Um, that's a loaded question. The
Or
pros.
what is your favorite and least favorite? Maybe that will help.
All right. So, my favorite thing about being the dentist is just caring for people in a usually a very predictable fashion. And then I guess my least favorite is the unpredictable cases, the things that you can't foresee. And then, but the beauty of that is usually there's another way to treat that patient. So, but that can be unpredictable situations can be trying.
If somebody has a crown put on their tooth and it hurts when they put pressure on it, what could be happening in that situation?
So the basic thing is that occlusion or the bite could be hitting that crown first and putting pressure on that tooth, which leads to kind of a bruise in the periodontal ligament, and that makes it sensitive. But that would be the first thought with that particular situation.
I see an interesting question. I'm actually curious what this is. So someone says they saw something about purple toothpaste that cancels out the yellow and white in them. Does that work?
This is just new, Al. I would be doubtful. I think it's kind of playing a trick on your eyes, but I'd have to look more into that. I don't know enough about that, but I have seen it. I have seen it.
Do dental implants last forever?
Well, hopefully they last forever, but as we know in medicine, you can't necessarily come up with guarantees. You can set yourself up for the best case scenario, but the beauty about dental implants is that they don't get decay, but they can be prone to not prone to, but they can get infected as well. So you have to guard against that with proper hygiene and proper placement and proper restorations.
After someone gets their braces taken off, how do you remove the bite blocks, or do they go away by themselves?
How do you remove the braces?
When you get their braces taken off, how do you remove the bite blocks?
You can just prepare them down. Usually they use a material that is blue in nature. I mean, sometimes I've seen white too, but you just prepare them down. They just will very easily prepare away.
Oh, there was a good one. Where did it go? Can a root grow back?
No.
Easy.
This is probably somebody's researching this somewhere. But no, right now it cannot grow back. Now, in a shark, yes, but not in humans.
Go ahead.
Okay, I keep doing that. This is cool. What are some things that a dentist can do to help patients that have sensory challenges? I like the question.
Oh, yeah, that's a great question. I mean, one is just taking your time and like explaining what you're doing, understanding the patient, and then another thing would be if there's sensory issues are too much, then you could think about some form of sedation. But people have different levels of sensory issues. So you just have to figure out where you are.
So there are a couple questions on toothpaste. What are your thoughts on charcoal toothpaste? Are abrasive toothpaste like Arm & Hammer baking soda harmful? Do they work? Do you have a favorite toothpaste?
So actually, my favorite is the Arm & Hammer toothpaste. It's not abrasive. I think it's the least abrasive. I do not like the charcoal toothpaste because they are very abrasive. And would, cause too much abrasion and can create problems. But I think if you find a toothpaste that has the ADA seal, I think you're fine with.
Would that also go for mouthwashes? Or is there a different regulation there?
Yeah. Again, the ADA seal, I don't have a favorite mouthwash. I just like the Arm & Hammer baking soda because it's sodium bicarbonate in it. Helps neutralize the acids and has a great effect on the gum health. So that's why I like it.
If a root cannot grow back, how does a root canal fail?
So when you're doing a root canal, it's not that you're not taking away the root, you're taking away the nerve within the root. And then you're placing a material in there, the gutta percha and the sealant, to seal that off. If for some reason that seal breaks down and there's a bacteria population within that root, then that root canal can fail.
If there is room in your mouth, can you leave your wisdom teeth in, or do they have to get removed anyway?
No, if there's room, you can leave them. But typically what we're seeing is there's usually not room. But yes, we have patients with wisdom teeth and they're perfectly fine. Now, that being said, sometimes they have erupted and they're in a malposition or they're very hard to cleanse, then you could make a case for getting those wisdom teeth out.
Yeah, mine came in sideways. It was very
Yeah.
unfortunate.
Oh no. Yeah, I got mine out last year. That was so fun.
Well, 3 of them were fine, but one of them was coming in sideways.
Oh God.
Are thin brown lines in the grooves of molars bad?
Not necessarily. That can represent staining, but it doesn't mean that that's necessarily decay.
When should you use a water flosser?
If you can use it as an adjunct to brushing and regular flossing. It just helps you keep your gum and teeth health healthy. I mean, it's an adjunct. I tend to favor an electric toothbrush and traditional flossing.
Good, that's what I use. Perfect.
But I
Yeah, same
understand.
here.
I understand that people can be challenged and also need more than just brushing, flossing, and the water flosser can help with that.
Have you ever seen an instance where wisdom teeth are removed too early, and does it affect a person's oral health if that happens?
I haven't seen that where they're removed too early. Usually we're coming up with a pretty good reason for taking out wisdom teeth before they're taken out. So I haven't seen that. And as far as affecting it, I mean, you can always have a complication with any procedure. So that can be an issue as well.
So what would you do if a cavity goes through the gum and veins? Does that happen?
No. So the
Okay.
Sounded awful.
it sounds
I was
awful.
like, oh.
The cavity will only exist within the tooth. It can go down into the gum level, but it's still on the tooth. The decay does not eat into the gum or the bone or the veins. You know, it will not do that. But usually, what happens when the cavity or decay gets down into the gum level or beneath the gum, usually there's some form of inflammation, and you could get an abscess formation as well. But that's not because the gum tissue is decaying. It's just the body's reaction to the bacterial insult.
Would you recommend any form of teeth whitening?
Yeah, I mean, I don't have any problems with teeth whitening. There's plenty of studies out there show you that has no ill effect on dental health. It just can cause hypersensitivity while you're using it. You can get zingers while.
How many years does it generally take to become a dentist? I know you kind of touched on this, but.
So you need an undergraduate degree, so that's 4 years. Then you need a dental degree, that's 4 years. Then you have a residency, that's 1 year. So a total of 9 years. And then if you go into a specialty, they can range from 2 to 6 years. So that can be a lot.
That's a lot of school, says the person who did a lot of school herself.
Yeah.
If somebody has silver on a tooth and braces at the same time, is it bad for the teeth?
No.
I like those answers. No.
So easy. What are your thoughts on holistic dentistry?
I think it has its place. I mean, it depends on what they're necessarily preaching, but I think there's a place for it.
How many cavities can you get in one tooth?
That's a good question.
How many cavities have you seen? What is the most number of cavities you've seen in one tooth? Maybe that's
so it would just be all surfaces. So like a surface of a tooth has an occlusal, I mean, for a posterior tooth has a mesial, distal, buccal, lingual. So you could see them on all surfaces of that tooth. And then also it can vary in size as well. You could have all 5 surfaces have some form of decay, but it could be very small and very treatable. And then in another case, you could have gross decay on all those surfaces, and then it would not be, may not be able to be restored.
There's a question in the chat.
Yep, I just saw, someone just said another one. I heard that once you start using sensitive teeth toothpaste, probably like Sensodyne, I'm guessing, you can never go back to using regular toothpaste. Is that true?
No, it's not necessarily true. It's, it's kind of trying to figure out what the etiology or the cause of that sensitivity is. I mean, the Sensodyne toothpaste or the too sensitive toothpaste can help while you're using it, but if you stop and you haven't identified the etiology or the reason for the sensitivity will more than likely come back. But if you identify and treat the reason for the sensitivity, then you could go off the Sensodyne or too sensitive toothpaste.
Last question. Have you done any volunteer work? And if so, what kinds of volunteer work exists for dentists?
So I've done a few things. I've done mission trips to abroad. I've done 2 missions of mercy, which is that's local. That was down in Salisbury, Maryland. And then I volunteer at the hospital in the clinic. So there's various volunteer opportunities. I see too one question was, did I work? I worked at New Moors for not the children's hospital, but the dental clinic when I first got out of dental school. But that was a paid position. That wasn't volunteer.
Well, thank you very much, Dr. Kelly. We very much appreciate you coming and chatting with us. We had, as you saw, we had a whole bunch of great questions. Everybody seemed very interested. I liked looking at the pictures, even though they made me cringe. Everybody, thank you for coming. Next week, we will be discussing neurology with Dr. Lee Dresser, and I promise you, I will have answers for you about what this whole Delaware Medical Youth Academy is. So thank you for coming, and we will see you next week. Thank you again, Dr. Kelly.
All right, thanks. Bye-bye.
Bye.